Good morning, everyone. Thanks for joining again. We will officially, I guess, be kicking off our first session with our keynote speaker. We want to welcome Christian Milaster, who is the founder and CEO of Ingenium, and he will be sharing about telehealth and the rural atmosphere. So, Christian, thank you and appreciate your time here today.
Thank you so very much for having me. I'm glad to be on. I found out about CRISP about 10, 12 years ago when I started working with LifeBridge in Baltimore. And I was like, wow, what a great idea to really exchange information between the different clinical sites. And so very glad to be talking to this audience here, and especially about that intersection of technology and healthcare delivery, especially in rural areas. And we're going to take you a little bit on a journey here today. I'm going to talk about Maryland's Rural Health Transformation Program goals that I'm sure are on some of your minds here. I'm going to talk about telehealth for rural health transformation. Then I'm going to share about a case study, our work in rural Washington state that we've worked for 5 years, and transforming access to care through telehealth. We have a little bit of a Q&A where I'll be looking at that Q&A box here. Let me just actually put that open here. And then we'll wrap it up with kind of a little bit more guidance of preparing for Maryland's RFPs, and actually brought just one open RFP here for us, just as an example. And if you live in other different states, again, your mileage may vary, but there's a lot of similarities across the various states that we're monitoring of how they're handling the Rural Health Transformation Program. Maryland's goals here, again, understanding that CRISP is used by many people in many different states, but again, just as an example, because almost all was derived from the CMS Rural Health Transformation Program that was launched last year. Maryland has a very simple approach, looking at three different pillars, looking at transforming the workforce, Pillar 1, and Pillar 3, empowering Marylanders to eat for health. So laying the foundation, but really the core and the bulk of the work here with 10 initiatives is the Pillar 2, promoting sustainable access and innovative care for rural Marylanders. So the rural health force, obviously, we cannot deliver great care if we don't have an educated workforce, if we don't have the right workforce in place, which is exceedingly difficult in rural areas. We can leverage technology. Chris is a great example of where we can leverage technology to really connect the different healthcare organizations so that a rural healthcare provider does have access maybe to the notes of a specialist that they received at an academic medical center. And then obviously all of us could benefit from eating and living better. And so promoting those resources, especially in rural areas, is one of the core aspects also of Maryland's program. But I want to dive deeper into that second pillar of promoting sustainable access and innovative care for rural Marylanders, because really rural health has been about access. I used to live in Minnesota. I now reside in Annapolis, and I'll introduce myself in a minute here. And I lived on 58 acres, and I had a 50-minute commute with one stop sign. And so and no grocery store in town and no clinical provider for at least another 25 minutes with a rural health clinic. And so, yes, so I understand what it means to live rural, and how it can be difficult. So here are the 10 kind of initiatives or activities under that pillar number 2. So Maryland wants to expand primary care and specialty practice capacity. That's actually one of the first RFPs that's out there. Increase the efficiency of local agency operations and strengthen emergency trauma response, and also expand school-based health center capacity. Now we're going to move into kind of the technology realm of optimizing health information technology connectivity and the use of CRISP tools. So CRISP explicitly being written into the RHP grant here, centralized telehealth infrastructure and sustainable access through service expansions and health IT advances. And so really it's that telehealth infrastructure that we'll talk about a little bit as well. And then there's 3 more. There's a mobile health transformation fund, so bringing care to the local communities with mobile health, which has some really great potential that we'll definitely going to be seeing some transformations happening in many different rural areas. An innovative care transformation fund, obviously, a lot of talk about AI and then the Behavioral Health Transformation Fund as well, focusing on one of the core challenges of access to behavioral health in rural areas. And so, again, a lot of these are leveraging technology-enabled solutions. A little bit about me here. Good morning, everybody. Again, thanks for joining. I've been passionate about optimizing service delivery in some other industries before, and then I stumbled into healthcare at the Mayo Clinic 26 years ago. I've been in telehealth since 2003. I've been working in rural health since 2012. Since 2018, I now reside in beautiful Annapolis, Maryland. And I've had a number of Maryland clients over the years. If you were trying to figure out my accent, it is German. I'm a German engineer by background and training. Came over here as a fully educated adult, and then stumbled at the Mayo Clinic, fell in love with healthcare, and then in 2012 launched Ingenium Digital Health Advisors, and also assembled a coalition of other boutique consulting firms focusing on rural health transformation. The presentation will be recorded. If you want a copy of the slides, feel free to send me an email. Happy to send you a PDF of those. So let's talk about why is telehealth such a great strategy, such a great tactic for improving access to care and really transforming rural health outcomes, meaning the health outcomes of rural residents. Well, let's start actually with something that I learned at the Mayo Clinic after way too many committee meetings is that everybody agreed until somebody defined it. And there are long, convoluted definitions from telehealth out there, especially from the government. I like things simple at times. And so here is a simple definition of telehealth, which is basically saying it's delivering care at a distance. Any interactions, any communication that patients have with their care providers, that where they are not in the clinic, in the exam room, that is they're receiving care. And so from a health systems perspective, clinic perspective, we are delivering care at a distance. Telemedicine is then about practicing medicine at a distance. So these are the interactions between clinicians and providers. Now, all these terms are used interchangeably these days. You also hear virtual care, you hear connected care. People say telehealth when they mean video visits, and so and for the most part that's okay. But so I like to organize things a little bit. Again, I'm an engineer by background, and so telehealth is the overarching term, which breaks down into telemedicine, teleeducation, as well as also the patient portal. So the ability for patients to self-service appointments, medication refills, that is part of delivering care at a distance. And then obviously also the teleeducation if you've been diagnosed with a condition and receive education, or if clinicians get educated by other specialty care provider with Project Echo, which oftentimes gets lumped into the telehealth universe here. That is that. Next, we have the interactive patient care as one of the domains of telemedicine. I will dive deeper into that. Also part of telemedicine is remote patient monitoring, the ability to monitor the vital signs of patients at a distance. And so I'm just clicking off some notification boxes here. Thank you. And then thirdly, store and forward. So faxing an EKG, right, a common practice for the last 80 years or 60, 70 years, is practicing telemedicine, right? Faxing EKG to a cardiologist for a review is definitely one way to practice telemedicine. Interactive patient care, that's the one where you find things like video visits, phone visits, telephonic care. You find secure messaging as well as e-visits. E-visits are interactions between patients and specialty care providers, oftentimes done asynchronous. It's still interactive, but it's more asynchronous. Remote patient monitoring, it can be automatic, continuous, can be self-measured or patient-generated. And then store and forward is the highest use case here is teleradiology. Nobody even talks about it or mentions it anymore because it really established itself as the de facto standard in many rural areas. Is that any X-rays, any radiological exams are being sent for review somewhere else. It's rare that we have a rural that we have a radiologist on staff. Teledermatology, tele-ECG, just as a couple of examples, and then also e-consults. E-consults being the interactions between the physician and a specialty care provider. And so really what you see here with Store and Forward, there's a mix of interaction between patients and physicians, and sometimes also physician-to-physician interaction to get consults, to get a read on something. And so, and this is also probably where somewhere in this universe, the health information exchange like CRISP would fit in. So this is kind of the domain of telehealth, delivering care at a distance, and practicing medicine at a distance, but you can also just roll it all into one. And video visits, secure messaging, and RPM are really the three main modalities that we're looking at these days, and obviously also some audio only or telephonic care. Said in a different way or looked at it in a different way, here are 9 of these modalities going from simple to more complex in terms of their of the lift that is required to implement them and to make them take off and have great adoption, and then also going from synchronous to asynchronous from top to bottom. And so here squarely at the top is the audio video televisits that we're all familiar with, what most people refer to as telehealth. During COVID, we had telehealth in air quotes, but which was actually mostly telephonic care because we had a lot of challenges in the population of actually getting the technology to work. And so after a few attempts, clinicians and patients threw their hands in the air and said, okay, let's just talk about telephone. And it was reimbursed at the time with the waivers during COVID. And then we also have the ability to remotely exam patients. It's used to a lesser extent, but in an elementary school, being able to have a video otoscope to look into a child's ear to diagnose an ear infection or whether it's just common ear pain, those are some great tools. So this is kind of synchronous care, very live interactive. More asynchronous is the periodic remote physiological monitoring, taking your weight once a day, taking your blood pressure multiple times a day, or glucose monitoring. We have continuous RPM, and that's the continuous glucose monitoring or some kind of implanted device, and then also patient-generated health data, meaning your Fitbit data, your Apple Health data. So those are some of the elements on RPM. And then we have store and forward of photos, audio, video, or data. We have secure messaging or secure texting as one of the key interactions that is really emerging, and we're still figuring out how do we pay for that, how do we compensate the clinicians' time for these messages. And AI is helping to some extent to field some of the simple dialogues and escalate it to a clinician. And then we have what is not much talked about, the digital therapeutics. What that means at its simplest form is a prescription of an app to therapeutically accompany your healing or your health maintenance. And so this is kind of like a landscape, just another subset of the taxonomy that I shared before, but these are practical examples. These are also things, this is a catalog that practically every state, every organization in any state that is applying for RHTP funding can select from, right? Can we expand access to telehealth? Can we use remote exam tools in settings where this is viable? Can we expand remote physiological monitoring to help with readmission prevention, to monitor patients after discharge, or to do chronic care management? Can we interact? Can we field patients' questions that they have at 3 a.m. in the morning through secure messaging, through secure texting? So we can stay in touch with them and interact with them. And so all of these, this is like kind of your catalog if you're thinking about applying for RHTP funding that you can choose from, and we'll revisit some of those here throughout the presentation. I wanted to acknowledge, I'm not sure how many of you are in rural, that there's a lot of barriers to access to care and access to telehealth in rural areas. So we'll talk about access. We'll talk about digital literacy, and then we also talk about engagement. So the access problems in rural areas are distance, right? No public or personal transportation, no gas money. There's no time off, working multiple jobs, and not being able to afford as an hourly employee to take a half a day off or a day off for a visit. And then also technology, having no device, no data plan, no connectivity, or limited data plan. So these are real barriers for picking up a smartphone or even having a tablet or a laptop to do a telehealth visit. And so the solutions here are public access points in libraries, community centers, which I'll talk about in the case study. Having intermittent clinics, meaning clinics that just like pop-up clinics, I think is what we would say these days, that are staffed multiple times a week where people can drop in and the equipment is already there. And then also mobile clinics. So mobile health being one of the key strategies of most RHDP programs as well. Um, and so, and that will be as well. So thank you, Rajani, for the question on billing. I will address this in the Q&A section here. Digital literacy is then the second barrier to access, right? Most people, most systems require an email account, and most people don't even have an email account anymore, or don't use it, or don't remember how to log into it. Right, creating and accessing a patient portal account, we have been fighting this ever since we introduced EHRs to the world, and they came up with patient portals. Just installing an app or troubleshooting sound and video problems, those are things that people usually do not deal much with. They use their phone for calling, for taking pictures, and then for some communication with family, texting, and maybe some social media. But really, all in all, not everybody uses their phone in a way that they could install a custom app. And so, again, we can have public access points like libraries that provide education. We can have digital navigators that provides people with devices. There's programs out there, and then also train them on how to use the devices. Community health workers. So Maryland's Pillar 1 around the workforce is one element, and also in clinic assistance after a visit, helping them to get set up for telehealth visits, and then a principle called telehealth checks that we developed during COVID in rural Vermont at an FQHC. The idea being that a few days before the first visit, or the first time a patient is doing a video visit, you would call the patient and you would say, hey, where are you going to be at the time of the appointment? Don't be driving, and make sure you have Wi-Fi or good connectivity. What technology will you be using? What's your connectivity? Let's make sure you can join with this link that we're sending you. Let's check your audio and video, your camera angle, and your background and your lighting, and then make sure that you maintain privacy, just that so that you're aware that people around you can hear you when you talk or when the clinician talks. Right. And this was established really by many organizations during COVID to really make sure that the patient and the clinician have a great experience even at the first visit. Good. So then the last one is engagement. And engagement is not unique to telehealth, but obviously in order to be take care of our health, to take care of our chronic diseases as patients, we need to be engaged. And one of them is keeping appointments. And so obviously keeping a telehealth appointments may be a little bit easier than keeping an in-person appointment just because of the logistical overhead involved in driving there and spending more time getting to and from that clinic. And so that is where telehealth helps to keep appointments, participation in the care plan. That means you need to frequently interact and enroll patients in it, and then just having the appropriate communication there. Just want to throw this in here, right? We have come a long way. When I started in healthcare, there was a lot of talk about compliance. Patients are not compliant. They're not doing what they're being told. They're not taking their medications as directed. And then we had a little phase where it was more about adherence. They should be adhering. And then really we shifted to engagement. And then there's another kind of movement or another shift happening where it's really about understanding that as the clinical care providers, we need to activate the patients to be engaged and participate in their healing journey and in their staying healthy journey, right? And so because really compliance will only get us that far, and we're not here to tell patients what to do. We're here to help them, to empower them, to do. And so this is where, again, where telehealth comes into play, and especially RPM is a great way to show patients what happens if they eat salty food. 2 days later, they gain some weight because of water retention. And so that direct correlation is a great opportunity for just-in-time patient education, specific, unique, and personalized to that patient. Another example where telehealth, delivering care at a distance, helps us to really achieve better outcomes or drive towards better outcomes. And so telehealth can make it easier to keep appointments. You can convert cancellations and no-shows into a telehealth visit, right? If a patient says, "Oh, I'm sorry, I can't come in this afternoon," and said, "Well, would you like to do a telehealth visit?" So we've worked with a number of our clients to implement exactly that protocol. And it keeps the appointment slot and it keeps the patient on track. Right, participation in the care plan. After a discharge from a hospital, you end up with a new regimen of medications. And so having a consult, ideally a video consult with a pharmacist to really go over the different prescriptions and how to reconcile that is a great way, again, to avoid kind of medical harm. Enrolling in RPM is a great way to do it. And then also communication, right? So seamlessly integration of on-demand video interpretation services. So that meaning if you have a second language barrier, and having live translation services is really beneficial, and they can easily be beamed into a video call. There's multiple services that do that. And then obviously AI solution. AI is already pretty well established and distributed in ambient listening and creating notes and also being able to create notes that are at the level of comprehension that is appropriate for the patient, also in the language of that patient. So that's where we're going. And so again, good. Thanks. Keep those questions coming. I'll address them. I'll take them later on. Here's an article that I write a weekly article on telehealth, and then this one really took off on LinkedIn. Some of you may be on LinkedIn, so this one had like 2,000 views the last time I checked. And because it really struck a chord, right, where a lot of people think about rural health just about the video visits, like shown in this picture here. But really, we have this opportunity to also include secure messaging. A lot of patients, we as a society are really getting used to just asynchronous communications with our loved ones, right? Sending them a quick message, either on Facebook Messenger or on WhatsApp or on just regular text, having group chats, group texts. This is the way we communicate. And so why couldn't we communicate with our care provider in the same way? The remote physiological aspect, meaning sending patients home with a blood pressure cuff with a scale that automatically transmits the data, and then giving the patient a call if the measures don't come back the way that we want them, and intervening and detecting the onset of disease early. Community telehealth access points, so being able to go into a location with privacy. And so then we really have this opportunity to go and help patients that don't have access to the technology. And then the last one that I covered in this article is community paramedicine. So the people that are already out in the community or at the place, at the patient, can they talk to a psychiatrist or a psychologist about that patient situation? Can they assess whether this is an admission to the hospital or whether this can be treated in an outpatient setting, in an urgent care setting? Right, so being able to make these life decisions is just really there. And ultimately, I see telehealth not as a cold technology that keeps us more apart, but rather it's a conduit. It's a facilitative tool to really enable us to be in touch with patients much more often, and to have access to the right information. So it's really about creating a sense of belonging, that somebody at the clinic cares about you. They respond to your messages. They make sure that you have access. They take a look at your vital signs and give you feedback if things are not going in the right direction. And people are equipped to give you help. And so these are just 4 examples of having rural health be going beyond video visits by leveraging telehealth. And all of that is now really available to us through that RHTP funding, right? The RHTP funding will fund 2 things. Well, they will fund obviously the technology. We need to buy some hardware maybe, We need to maybe give patients some devices. We need to have to pay for licenses for the software vendors that provide those technologies. But then also the big part is that we can pay for somebody to actually implement and launch this well, because the vendors focus on the technology, but the workflows, the processes, the policies, the support structure, all of that needs to be established as well. If you've ever launched a new thing in your healthcare organization, you will understand what I mean. It takes a lot of heavy lifting, and so this is where RHTP funding really can be leveraged to get these programs off the ground really, really well, because there's no constraints really on that level of technical assistance. All right, so that was kind of setting the stage here, and now we're going to be moving into that case study, improving access to care through telehealth, kind of a 5-year collaboration that we did with Thriving Together out of Central Washington. I'll introduce that organization in a minute. And we also had a Maryland-based firm help us to do an impact analysis, which I'll talk about a little bit. So this is Washington, Washington State. There's 4 counties, which is almost half the size of Maryland, or probably maybe 2/3 of the size. And so 260,000 residents only. So very rural, or Okanagan County is actually frontier, and Douglas County as well. You can see Seattle and Spokane there. And then also the tribal region is also part of that community there. Washington divided itself up in 2017 into 9 different ACHs, and so this is the one that we have worked with for the last 5 years with this telehealth program. The vision for this telehealth program was that every resident in the area can easily access all the care they need, where they need it, when they need it, and with all we mean primary and behavioral dental, chronic care, rehab care, specialty care. So all of these different elements of the care spectrum, because obviously there's primary care and behavioral health that's local, but specialty care can be a challenge. Dental care can be a challenge. And then the mission really is to improve the wealth and wellness in the Thriving Together community, which is part of their overall mission statement, through telehealth, really leveraging telehealth among the clinical partners, as we call them in this engagement here in this context, and then also the community partners. So the funding principles were that all investments must directly benefit a community initiative. So it's not just goes directly to a healthcare organization. We always looked at equality and equity as we strive for that balance, and so that there's a physical presence in the region. So this funding was not going to go to virtual only providers. And then we initially set out with for 2.5 years, and we're now, I think, in 4 years when we launched this after the initial assessment phase, and everything will be customized and individualized for each community, for each care provider, for each patient population, and so there are some nuances across this wide geographic regions that each kind of initiative, each project had to consider. This is kind of our timeline. We have done a number of telehealth services assessment through the end of last year, I think 16 or 17 in total. We've done work with numerous organizations on telehealth program optimization. That meant either relaunching primary care telemedicine, or that meant optimizing behavioral health telemedicine. And we're still working on it with some partners there. We've been looking at a baseline impact assessment, an interim assessment, and now this year, the final assessment on the impact of those activities. We're looked at school and library-based telehealth as part of the partner framework here. And then we had some additional funding that allowed us to do a real telehealth expansion kind of during that time period. And then also part of this program was to embed and leverage digital navigators to give patients access to technology and access to digital literacy education. So what we did here for the community access points was a multi-pronged approach. A lot of community access points like school-based telehealth, maybe even library-based telehealth, are oftentimes the effort of one clinic, of one health system to pay the equipment, install the equipment, and then that is an access point for that, for patients of that clinic, of that care provider to provide access. We used a kind of a provider agnostic model here. We focused on working with the FQHCs, the rural health clinics, and associated critical access hospitals, behavioral health clinics, and addiction treatment centers, and then also worked with the schools and libraries, fire stations, and community centers. And so when you have a digital access point, a telehealth access point, or a digital access point, really in this case, then you could have a clinical partner number one that provides behavioral health services there, and you could have a second clinical partner that provides behavioral health services there. So it's a resource that can be leveraged by the community, by the clinical partners. And clinical partner, if that's an FQHC, they may also provide primary care services at that same location. And then we may have a third clinical partner that provides specialty care, so giving them access to maybe specialty care providers from Spokane and Washington, and then social services partner, right? Now that we have this infrastructure in place, could we also allow people to connect with video-based service providers that already have a video option and allow them to connect so that they don't have that technology barrier and they don't have to drive in? And what we mean by social services is kind of based on this, let me just, on the seven vital conditions here that Thriving Together is using as their compass. And so here on the right, you just see some of the sample social services we've explored of integrating. And because then really it's about healthcare going beyond just beyond clinical care, because there's all these other social determinants of health, or these other seven vital conditions that we want to make sure that people have a job and people have access to childcare, people have transportation, people have access to education. All these elements, all as we now understand, increasingly have an impact on a person's health. And so leveraging that infrastructure that was initially established for video visits is a great benefit. Then also to take a look at, can we also use that to expand access to those social services, which oftentimes are hard to come by in very rural areas. I want to dive a little bit deeper into telehealth assessment. When we started out in 2021, the Washington State University did a community assessment using these methods, and really found out something, or confirmed something we already knew: lack of broadband access, lack of technology, distrust of telehealth, and digital illiteracy. And so the common challenges that really are not unique to any specific area. We then also have, as I mentioned, over the years here, assessed 14 different total organizations on interviewing the staff and the leadership team, and taking a look at their use and their attitude towards telehealth, and then develop them kind of a draft telehealth vision, some improvement recommendations, and an overall kind of telehealth maturity ranking. So an instrument that we developed. You can see it here. Just bring it up all at once. It goes from level 0 to level 6. And what you see here with the circles in red were the initial baseline assessments of all the organizations, and you can see here some of them didn't move forward. Then the arrows and the green and or the teal colored, those were organizations that we've worked with a number of times, or we did to telehealth program improvement. And so you can see here the progression of their maturity level as we worked with them. And really, this is kind of one indicator how we really increased clinical providers' level of comfort and confidence in offering video visits as a viable alternative option to having to come in. So few words about measuring the impact by our colleagues from Laurel Health Advisors, and that's Laurel, Maryland, named after Laurel, Maryland. So we looked at community assessment, we looked at key informant interviews, did a provider survey, cost effectiveness analysis, and the roadmap. Again, this is the framework that we created for the baseline assessment. And so the bottom line is here that there was a 10% reduction in hospitalizations that was found in the data, ultimately, and then also a decrease in cost through the utilization of telehealth. If you know anything about assessments, always, of course, the data always lags 1 or 2 years behind. And so these are some of the effects that we had seen already from COVID, where basically everybody was forced to engage into telehealth. What was very interesting is the kind of financial analysis that they've done across these 4 different counties, across these different conditions. Ultimately, the bottom line being that there's a $220 million of savings across those 4 counties, across those major diagnosis codes that can be attributed overall to the use of telehealth. And so now we're working on an impact assessment after we have done all these interventions, and want to see where the numbers have gone here. What is the utilization? What is the impact? And no news here, but the findings were telehealth improves access to care. It reduces cost in terms of travel, in terms of hospitalization, and hybrid care is very cost effective. And so people want, especially in rural areas, want to see the clinicians, want to interact with the people, but sometimes it's not possible. And then you have an alternative option. So telehealth here is not to replace in-person visit. It's intended as an alternative when it's preferred by the patient, or when that's just not possible to come into person, because telehealth is always better than no visit at all. That is really the comparison. It's not in person versus video visit. It's video visit versus no visit at all, which is oftentimes the choice. And so we do need to educate. You saw on the first slide there of the assessment that there was aversion against telehealth, and really addressing the patient and engaging the patient is important, and making sure that there's policy and reimbursement there. Good. And so we're then going to go for an impact assessment here. How has telehealth affected healthcare access? What impact have they had on utilization? Has it addressed health disparities? And has it increased the capacity to care for patients in the community? So that's what we're looking for in looking at the 24-25 data to assess here in 2026. In order to implement the telehealth program then, and if you are considering of launching telehealth or any kind of digital health in your organization, leveraging the RHTP funding, which is kind of the hybrid theme here, focusing on rural health and focusing on the Rural Health Transformation Program funding opportunities, here's a nice framework that we've developed over the years well, if you first start out with an idea, right? You have multiple ideas. Maybe you want to do community paramedicine. Maybe you want to train community health workers. Maybe you want to do telehealth in a school. Maybe you want to establish a community access point. So really different ideas. And so first thing, obviously, we need to have a prioritization funnel and apply some criteria to see what first matches the RHTP funding, but also what matches your strategy, and most importantly, what matches the needs of your community, and also the willingness of your clinicians and your staff to undertake this, right? So this is very important, which is why we always start out with a verification step. Let's build the strategic case for this, and align it with the overall strategy of the organization, as well as the objectives laid out in the RHTP program, and specifically any funding opportunities that are in front of us. What is the financial case? CMS is very clear with the RHTP funding that all the things that are being established should be financially sustainable. They should not rely on the grant funding to run them. So the funding is, what I said earlier, really for the purchase of technology and that, but most importantly, actually for the actual launch, the project management, the process design, or what I call solutionization. Right? What are the different workflows? How is the workflow different for a video visit than an in-person visit? What's the workflow for RPM? What's the workflow for secure messaging? And then what's the billing process for it as well? What technologies do we need, and what support and training do we need? And so this is where the bulk of the RHTP funding is going to go to, is through this design of these new ways of improving access to care. And then launching it on a small scale with a few excited providers. That's the best way to do it from a change management perspective, to really validate and to fine tune. And then you can go with a larger deployment, leveraging change management principles. So really making everybody aware. And I have a change management tool here on the next slide. And then underlying all of that is some sound project management to make sure that all the stakeholders are engaged, are communicated to, that we track all these activities, and that we deliver to under that RHTP funding. So this is kind of a nice framework. Again, feel free to send me an email, reach out to me, and I'll send you the slides, and then you can use this to kind of plan your RHTP application as well. Investing in Thriving Together Land, as we like to call it, in North Central Washington, into telehealth allowed us to do a number of different projects. We optimized and grew telehealth programs, mostly video visits, but also this year we're now still on 4 RPM projects that we're launching. No-show cancellation conversion, remote patient intake in behavioral health, tele-SUD services, telecrisis at 4 ERs, and teleinterpreter for crisis. Those are just some of the sample projects that we've done with our clinical partners. We had a school-based telehealth strategy that we worked with the Educational Services District that combined 29 of the school districts in the region, established telehealth in 5 schools. It's now 8 or 9. And developed an implementation playbook and established some performance management skills and library similar to the schools. We launched at this stage in 2 libraries and an implementation and performance management. When I say implementation playbook, that's not this slide. It's coming next. Here's our framework for telehealth optimization. We look at critically and most importantly around clinician engagement, right? How do you engage your clinicians? Because ultimately clinicians need to embrace video visits and RPM and secure messaging because they are the ones that are getting impacted because it's about delivering care or practicing medicine interactions with the patient. And so getting the clinicians on board, getting them involved in the decision process, in the design of the workflows is absolutely critical. And that's our first step. Then we need to work on the workflows and the policies, need to select the right and user-friendly technology, and overall really need that leadership support and governance and also establish some support functions, not just on the technical side, but also on the operations side. This is best anchored in a virtual care strategy or a telehealth strategy that lays out what's our roadmap for the next 3 to 5 years of what telehealth services do we want to launch. Making sure that we're managing the performance, which is very critical for RHTP. And last but not least, it cannot be the best kept secret. So we need to market, we need to raise the awareness that for patients and for clinicians that this is now a thing. And so this is kind of how we frame any effort into optimizing telehealth or growing telehealth. And so some RHTP funding can also be used for that. If you have a sputtering or early beginnings telehealth program, you can now build on that foundation and do that. So questions are coming in here about the insurance, the payments. And so the general answer is yes, video visits for the most part are paid for by most insurers, Medicare, Medicaid. But there are nuances and there are restrictions and there's limitations. So this could take a whole another webinar or actually workshop to go through. And good. All right. Here's the example of the school-based telehealth workshop here, NCSD schools and clinical partners. And then here's a snapshot. Jessica, I see people coming in. Should I sorry.
You're good, Christian. You're plenty of time.
All right. Okay, good. Okay, thank you. Just wanted to make sure. Here's the map of the 4 counties again, and then all the different care providers that you can see here that we've launched in different areas. You can see the geographic distribution. It takes about 6 hours or 7 hours to go from north to south. So it's a huge area. And then the stars are the different school districts. Here on the next slide is another example of where let me just get to this, where we mapped kind of the 16 schools, 3 libraries, 4 EDs, 2 clinics, 2 jails. So really those different sites where patients can access that. And I'll address the HIPAA question here right away. So yes, using the public internet is not a HIPAA challenge because it's the software that's being used that needs to be encrypted. That's part of it. And then obviously you need to ensure privacy. So a library computer out in the open space is obviously not a good way to do this, not only because of privacy concerns, but also it will disrupt the quietness that we expect of patrons in libraries to maintain. And so they're either in separate designated rooms or they are located in separately installed booths that are soundproof or have a noise machine out of it so that you cannot accidentally overhear. But again, when you're at home as a patient, you're using the public internet, if you will, as well. And so it's the same rules apply. It's all solutions are end-to-end encrypted. And so from that perspective, there is no HIPAA concern regarding that. But you need to use a platform that is HIPAA certified. CMS waived that requirement, or somebody waived that requirement in the beginning of COVID, so that you could use FaceTime or any other tool which were not HIPAA certified. And so they didn't waive it. They said, well, we're not going to go after violations. But that only lasted 2 years, and now you need to use a tool that is HIPAA certified. So the major successes is that we were able to have a rapid expansion in 2023, building on the relationships that we had. And so when new funding came in, we were able to move very quickly with over 24 of expansion projects because the relationships were built. And so that was great. And then also put together a very comprehensive DLT grant proposal for the USDA that involved a lot of the clinical partners and a lot of opportunities. And the hallmarks of success were really about a relentless focus on change management. And that is even more so important in rural areas, which are prone to be more conservative. But just change is hard for any human. And so clinician engagement is really key. That we really define the processes and workflows as I've laid out, and that from ideas to serving patients flow. And also the idea that the Thriving Together brought us in as the telehealth implementation experts, because that knowledge was not available and still is not really available in the areas to launch a new telehealth service. Now they have been prepared and they are running the telehealth services very well, but launching something is very different than running something or even improving something. And so having that expertise out there and letting the clinicians and the administrators focus on their organization has worked really well. But it requires also being very flexible. This is one of my favorite tools, and I'll try to weave it into any presentation, because we are all in the change management business. We're all trying to influence the behavior of others. We're involved in change ourselves, being thrust upon us. And so in order to achieve change, you need to go here and raise the awareness. Why is the change needed? Create the desire, provide the knowledge and the ability, and then provide reinforcement. What I like about the ADCOM model is that it's a diagnostic tool. If you're experiencing confusion, it's because people were not made aware. If you're experiencing outright resistance, it's people don't have the desire. If you don't have if there's reluctance, then people don't have the knowledge. They want to make any mistakes. If people are frustrated, and then you don't provide the ability and reinforcement. This applies directly, right, to CRISP as well, right? So if you don't know how to use the tool, if it's not working well, if there's no the ability, then we have some frustration. If you don't know how to use it, then there's reluctance, and if people are not being encouraged and reinforced of using it, then there may be some backsliding of not using it or doing the way you've done it before. So and this is just a really, really great tool. So I want to take a peek at the questions. I think the ones that were left on here I answered. So public access internet incur HIPAA implication. As I mentioned, it's end-to-end encrypted. All the HIPAA certified platforms are. And in addition to the technology certification, we also then, or there's no certification, but HIPAA compliance platform, we also need to ensure that obviously the patient can be overheard. Also, when a patient presents at a library, they said, I'm here from a medical appointment with Dr. Miller about my diagnosis, right? That obviously we cannot do that. That would be a HIPAA violation. But if they say, I reserved the video room here at 3 p.m. and said, oh yeah, let me take you back there. Right, and then they're left to their own devices. So this is how we ensure, like in a public space, that there is no accidental disclosure of public health information beyond what the patients want to disclose. Many librarians have told us a lot of stories about that. They know more about the patron's financial situation or healthcare situations by helping them to just navigate the computers already. But if the patient discloses it at their own discretion, then it's not a violation. So good. Okay. My email is easiest one is christian@rhtxa.com, but maybe that can also be shared in maybe the description of the video, and I can maybe I can even make a link available to that PDF. So, any other questions here? Do you have any experience doing acute telehealth in the pre-hospital settings? Yes. Special challenges you face. So, the primary use cases in the ED are about teleneurology, telestroke assessments, and then also the telebehavioral health assessments. And the challenges are really about the workflow integration, right? Somebody needs to be in charge of moving the cart and charging the cart, or ideally, all the rooms are equipped with that technology. There needs to be a clearly defined process that needs to be trained and retrained over and over again. And so those are some of the challenges. So it's basically the same. It's about workflow. That's the key part. Tried ambulances, mobile phones. Yes, I mean there's ambulances that can drive through different areas, stay connected over satellite, over different provider networks to stay in touch, to have a live transmission of the EKG and the vital signs, for example, to actually already talk to live with a patient how they're feeling even before they get delivered to the ED. And so again, I like the statement, the future is already here. It's just not evenly distributed. If you can think of it, somebody in America has done it somewhere and has figured out that it is challenging, but also easy. So, Jessica, I still have a few more slides. Do I still have time, or what's my timing here?
Yeah, if we could have like the next couple minutes, that would be good. But if you're
Okay. All right, good. Again, there's a lot of text on these slides, and I provide a lot of information and so maybe by now you've reached a saturation point. But I want to bring one point home here, and really look at the outcome measures that CMS is pursuing. I'm going to go a little bit faster here, but I want you to take this one away, right? Most healthcare organizations are going about anything digital health in this way. They select a vendor, they purchase the equipment, they train the staff, and then they count the logins or distributions, and then they hope that outcomes improve. What we're suggesting is the better approach, and especially for CMS, is let's define the outcomes first. What is the patient condition we want to see improve? And we can have some surrogate output measures, as we'll see that Maryland did in their current RFP. You want to establish a baseline. Where are we at in terms of utilization? Then design the intervention, and then select the technology. So design backwards from the outcomes that you want to achieve before selecting a vendor is what I want to kind of bring home here. And then because outcome measures is really what CMS is asking for, I think the states are going to learn some hard lessons in this first year. That because a lot of them have put more input and output measures into it, and CMS is really driving towards outcome measures, not just output measures. So let me bring to you here this on this last slide, the current Maryland RHTP opportunity. It'll be linked in the PDF. It's due June 1st. Right now, just 6 million total, up to 1.6 per award. Anybody can apply. That serves rural areas, and it's about strengthening personnel, technology, and operational capacity. Here are some sample eligible activities that were listed that are relevant to our presentation today, like implementing secure messaging or patient portals, implementing telehealth technology and virtual visits. And when they say implementing, right, they may just say, find a vendor and launch it. What I'm saying is, what are the workflows? How do you raise awareness? How do you get patients to use it? How are you going to support patients? How are you going to tracking success? Right, these are the elements that are really beneath the surface. This is just the tip of the iceberg, finding the vendor, as I mentioned before. And so this is really critical and important. And then here are some sample output measures that they have indicated. The net increase in primary care capacity, because it's the expanding access to primary care grant here, and the number of patients served by the practice. And so those are some good output measures. But ultimately, what I want to see is, what's the reduction in hospitalization? What's the improvement in A1C values? What's the improvement in hypertension diagnoses and treatment? And so those are the things that really, I think, over time, the RHTP program, CMS will come down on the states and said, no, you've got to measure outcomes, not just outputs. With that, I covered a lot of ground. Thank you for being here. Thank you for the good questions. I still have a few minutes, so have there been reluctance to using schools or libraries, and is telehealth offered through synagogues, mosques, churches, or other religious facilities? Very great questions. And yes, resistance occurs if there's no engagement. And so the change management part is one of the hardest challenges here. There are some access points that are experiencing high utilization, but it's really it's a joint effort of the community as well of the clinical providers to really promote this and make it easy for patients to use. There have been I have not been involved in any church-based telehealth opportunities, but that is definitely the case. But with that, I thank you for your time, and I think we have another one, another speaker here. So thank you very much. Reach out to me. I'm happy to engage with you and send you the slides. Thank you very much, everybody.